Hello everyone, this is the bone mineral lecture with a focus on osteoporosis. Just a brief review of physiology associated with bone construction because it is important just for the general mechanisms of action of the drugs we're going to talk about and really focus on one class of drug by itself and then talk about a couples in periphery. But anyway, calcium and phosphorus being the main components of bone, and you can see kind of the structure there. Obviously, we don't really care too much about that, but what's more important is how the bones are built down and or built up, excuse me, and broken down. And that has to do with the osteoclast and osteoblast process. So osteoclasts break down bone matrix, and osteoblasts build. I always remember blast for build or B for build in case you're trying to get those things, because for some reason I always have it in my head that like blast means to blast the bone apart, and I have to like keep it straight. So blast, build. And that's basically how we make new bones. So if we want to manipulate something with drugs, we're probably going to focus on these systems by preventing the body from breaking down bone or adding something into the system that's going to increase the ability to make bone, which is less common of a mechanism. This is my joke of the day. I've got 3 physiologic regulators, and I've got Nate Dogg and Warren G over there. The 3 being a parathyroid hormone, calcitonin, and vitamin D, and the target tissues being the bone, the kidneys, and the intestines. Now, we already talked about a lot of this last semester with respect to the kidneys, so I'm not going to spend a ton of time on that specific process, but just to review the calcium component of this, it is really important because all these things sort of have to be in sync, and so we need to consider a couple different areas here. So first of all, vitamin D and where it gets synthesized, where it gets processed. So if somebody has kidney disease, of course, remember vitamin D isn't going to get processed the same way. So supplementation is necessary, so that can certainly have an effect on osteoporosis. Parathyroid hormone has some roles in homeostasis as far as how the bones uptake calcium and maintaining serum calcium homeostasis. So for example, if serum calcium dips down, it might invoke sort of the osteoclast process so that you get an increase in serum calcium. And calcitonin has to do with some other areas of the body, as you can see here, but it can directly cause feedback into parathyroid hormone and to the intestines to alter the amount of calcium your body is going to intake from dietary sources. So, all 3 of these things kind of work together, and we're going to talk about different drugs. There are some drugs that work directly as parathyroid hormone analogs. You can give calcitonin as basically a synthetic version of the exact molecular compound, and of course we have vitamin D options as well. So just talk about these a little bit more and talk about what they do specifically. Parathyroid hormone, you can see here what it's doing to calcium. Essentially what you've got is it's upregulated and it releases from the parathyroid gland if there is a decrease in free calcium, so it maintains plasma calcium concentration, and it's basically mobilizing calcium, and of course that's coming primarily from bone sources, so it's breaking down bone. So if your parathyroid hormone, or if your calcium is chronically low and your parathyroid hormone is constantly getting upregulated, you're going to end up breaking down bone faster. So that's why one of the theories behind this whole process is to keep calcium in adequate levels in the body is actually really important. Now, studies will show, and I'll talk about this later, but that maybe that's not as clinically substantial as we think, but logically it makes a lot of sense, right? You have to have some calcium in the body or enough calcium in the body to make new bones, and if you don't, your body is going to tap into those sources of calcium, because we use calcium other places and channels and receptors, like specifically in the heart and muscle tissue. So we need calcium and a certain amount of it, and if it gets low, you've got a huge reserve of calcium in your body, and that's your bone source. Of course, we don't want to break down bone, but you can see where that's where the problem can occur, where a chronically low calcium level can cause issues, because the parathyroid hormone will tap into the bones as a source of increasing that. So anyway, parathyroid hormone will have an increase in serum calcium too, and it'll decrease phosphorus. It also has some other things there that works in the kidneys and increases synthesis of calcitriol. Calcitonin found in the thyroid gland. Whoops, excuse me. Let's do that tomorrow. Inhibits bone resorption by inhibiting osteoclastic activity, and then it has some effects in the kidney. Your net effect is going to decrease serum calcium too. or calcium, calcium 2 plus, calcium ion. We talked about vitamin D quite a bit last fall, right? So we'll talk about it again very briefly here. Basically, there's a couple different vitamin Ds to think about. So I haven't talked about the supplement and mineral lecture and herbal stuff, but over the counter, you're going to see two different forms of vitamin D, ergo and cholecalciferol. What's probably the more common one people get is cholecalciferol. I think about ergocalciferol, it's vitamin D2. It's sort of the dietary source of intake of vitamin D is mostly going to be found in that. So like fruits and vegetables and things that are rich in vitamin D are going to have this particular form of it. Cholecalciferol is vitamin D3, which is the one you synthesize from the sun that your skin makes. Both can be used and both can be changed. D3 is thought to be a little bit more of an effective option for people looking to supplement, but they're both equally okay. Intestines causes absorption of calcium. So that's the big thing here, and why we can't probably say this enough, why we combine these two so much is that there is that link between how the body absorbs calcium and what vitamin D does, and that's really its major role in this particular area. So we do need vitamin D to absorb calcium. You can consume a lot of calcium from dietary sources, but your vitamin D is lacking, you aren't going to absorb quite as much. And then there's some other effects in the bone, calcium mobilization, calcium 2 resorption in the kidneys. Okay, so let's talk about osteoporosis and what kind of drugs we're looking at and why we're treating this and what sort of a pharmacologic approach we can have to prevent fractures and brittle. And overall, that's kind of what we want to do. As people get older, they are at higher risk for falls, and falls result in fractures. So hip and vertebral fractures are kind of the two things we're going to talk about reducing the risk of. Bone mineral density T-score is still the gold standard for diagnosing and treating osteoporosis and osteopenia. And here you can have the different T-scores and what they correspond to. Goal of therapy, we want to prevent fractures, like I just said. So risk factors, people of advanced age, especially postmenopausal women, and I'll show you a chart here in a second, but basically postmenopause, it's difficult for women to maintain as much bone mass as men. Previous fractures, long-term glucocorticoid therapy can cause osteoporosis risks, and we're talking about long-term, not just like, you took a steroid burst for a couple of weeks. It's like, you've been on steroids for years because of, like a anti-rejection regimen for transplant. Low body weight, less than 58 kilos or 127 pounds, so smaller people, cigarette smoking, excess alcohol, family history as well. Those are kind of the things you'd think about. But at the end of the day, the T-score is going to be a really important component of making sure that we're diagnosing properly as well. Non-pharmacologic is really important for this. Exercise, weight bearing, and resistance exercise has, I say, obvious benefits, but also you help strengthen your bones in addition to the muscles. Fall prevention, educating people. I think there's, I don't know if anybody's heard about this, but the walk like a penguin, when you're walking on ice, I don't really know exactly what walk like a penguin means. It's kind of funny, but keep your knees loose and arms extend. I think about this, my kids were watching some show and there were penguins on it, and they were singing this song about walking like a penguin, and my son decided to do like a walk like a penguin dance, and it was, I don't know, I wish I had a video of it because it was ridiculous, but I don't think that's exactly what they had in mind. However, that is the general thing is keep your knees loose, extend your arms, try and keep balance so that if you do fall, you can maybe try and catch yourself or something like that, or at least you're a little bit more balanced. You just don't necessarily walk like you normally would. But if you're elderly and mobility is an issue, walking like a penguin might not be something that you're even necessarily capable of doing correctly, especially if you don't really understand what that means. So just discussing environmental risks that the person would take. Do they have to go up downstairs? Do they have some sort of walking assistance device like a walker or a cane or something like that? So we want to try and prevent falls in these patients, because even with good medication management and non-pharmacologic management, you still have the issue that if you fall, you still could be at risk for breaking a hip or something like that, even if your T-score is not all that bad. Non-pharmacologic, other options or other things to talk about. Benefits, there's no real cost to this. Modestly effective. It's something recommended for everyone. Lifestyle is designed to be synergistic with our pharmacologic options. And overall, just lifestyle modifications generally always are sort of like the logical step, right? If we could do these things, we'll probably improve, but it might not get us all the way to our goal of improving your T-score. So it's a good start, and it's something to consider and definitely recommend to your patients, but know that you might have to do some other options as well. All right, calcium with vitamin D. Calcium intake is recommended to be 1,200 milligrams per day elemental by dietary or supplements. So you might have to talk to your patient about how much calcium they're drinking. If somebody doesn't consume a lot of dairy products, they probably aren't getting a ton of calcium in their body. Of course, there are other sources. There's fortified calcium products like, non-dairy milk alternatives usually have some calcium added to them. So there is that. But overall, if they aren't getting a lot of calcium in, they probably should be on a supplement of some kind, especially if they meet some of those risk criteria we already talked about. Calcium supplements are basically benign. It's very difficult to take too much calcium. If you take too much, you probably just won't absorb it. Theoretically, the only risk is if you took too much and absorbed too much, you could end up with some kidney stones or possibly even cardiovascular complications, but that would be very unusual. Probably not going to see that. And again, calcium supplementation, if you're doing it once, twice, or 3 times a day, is benign. It's very rarely going to cause any issues with somebody. So from that perspective, if you're weighing out risks and benefits, your risk to supplementing calcium is extremely low. The benefit might be there. The evidence is a little sketchy, but we think that, again, logically, if you're going to have good bone health and support for your bones, you need to have adequate amount of calcium available to prevent your body from breaking down your bones. And that's where the logical step comes in here to supplement calcium. Vitamin D recommended is 800 international units daily. D3, again, I said was kind of preferred over D2. And it seems just in a few different studies that you get an increase in serum concentration better. And that D2, interestingly enough, is not always detected in laboratory tests. So sometimes if you're doing a vitamin D level on a person and they're supplementing with D2, it's not going to show up universally in all different lab tests, whereas D3 will be more easy to measure. And then vitamin D won't really do anything without calcium. So calcium is really what we want here. Vitamin D is just helping us get it into the body. That's really its only role in this particular thing. And I'm not saying vitamin D has no other benefits elsewhere. We just really haven't talked about them. And for this particular disease, that's really all we care about, is getting the calcium into the body. So that's the most important step here. And then again, just like calcium, vitamin D is basically benign when given in standard doses. And in fact, even if you overdosed on it significantly, I don't think it would cause a ton of issues. Not that I'm recommending that, but it's something that you can't really overdo as far as over-the-counter supplements go. A lot of people take 1,000 international units daily, and that's perfectly fine. I think over-the-counter you can get up to 5,000 international units daily, which is probably a little bit overkill unless you measured that person's vitamin D and it was really low and you wanted to supplement aggressively. I think during the kidney lecture, I also mentioned that there's a large dosage form of ergocalciferol. That's a 50,000 unit. That's 50,000. And that one is a prescription-only product. And when people take that, they usually take that like once a week or twice a week for a couple of months to get their level up. And then they taper off, then they switch to a lower dose, like 1,000 units a day, to maintain that. So it's usually a temporary thing, not a chronic thing. But just know that if you did want to supplement aggressively, there are some options out there. But most of the over-the-counter stuff comes either as 400, 800, or 1,000. 1,000 is probably the most common one I see people taking. The data for calcium vitamin D is overall kind of questionable. The trials are limited in some of the questions they looked at. So for example, some studies didn't even look at baseline bone density or calcium vitamin D levels before looking at end outcomes of fracture rates. So it's kind of hard to say if supplementing a person did all that much good if they had normal levels to begin with, right? Or normal bone density to begin with. So that's the bigger bodies of data have this kind of gaping issue with why they didn't look at the right stuff initially, probably because they looked retroactively and didn't necessarily have the ability to do that. And vitamin D and calcium are really cheap. There's not a lot of evidence or not a lot of rationale to support spending a lot of money on a clinical trial for them. So if you're a researcher, you're looking at where you spend your dollars. Basically, from a logical perspective, we can say, the body needs calcium. Calcium is necessary for bone health, and we need it to rebuild our bones properly and to prevent bone breakdown. Vitamin D is essential for calcium absorption. So again, logically, it makes sense that you would supplement this in somebody if they have osteopenia or at risk. In fact, I would probably recommend anyone kind of on that risk table that I just showed you on a couple slides earlier, risk slide, you'd probably recommend a calcium vitamin D supplement. Now, is it going to be an absolute guarantee that they don't get a fracture? No, I mean, we can't ever do that, but it's going to be something that has very low risk, and really there's only an upside with it. So I recommend it personally, and again, even though the evidence is a little bit sketchy and not as good as we would like, just know there's a lot of limitations to how that evidence was collected, and no one's really done there's been some studies that are better than others, of course, but there hasn't been a great robust study, and that's again just because no one really feels the need to do research into this, I don't think, because it's sort of a foregone conclusion, maybe that's just been grandfathered in. And again, I think it makes enough sense to recommend that to somebody, and it's low risk, and I don't think that's a very controversial stance, but again, you might hear other people's opinions on that differ than mine. Here is a study from the New England Journal of Medicine from '97 that looked at placebo versus calcium vitamin D and did actually show a clinically or a statistically significant decrease in non-vertebral fractures. And I don't have another chart on here, but the Women's Health Initiative is something I'm going to talk about this summer a little bit more, but it's basically was a collection, kind of like a meta-analysis, looking at a number of different aspects of health concerns that affect women, especially looking at postmenopausal women in some aspects. And they decided that calcium vitamin D did generally have a benefit to postmenopausal women, and was a recommendation based on the bodies of evidence. So there's a couple different groups out there and a couple different studies that have said that, yeah, we think that this is something worth doing. And again, it's up to you but most people will probably agree, and they might even like it because you can kind of sell it as a non-pharmaceutical option and say, it's over the counter, it's relatively inexpensive, and it might help you in the long run. So postmenopausal women usually have two different factors going into affecting their increase in bone loss. Low calcium diets coupled with a decrease in estrogen. So estrogen causes increased bone loss, or estrogen deficiency, causes increased bone loss, and then the lack of calcium doesn't improve the situation because you don't have anything to rebuild your bones with. So that's where, as females progress through age, both men and women will decline, but women will take a pretty huge hit during their menopausal years and drop significantly further than their male peers, just due to that lack of estrogen. For men, lacking testosterone, we'll talk about that very briefly, can also affect bone mass too. So sex hormones can certainly play a role. All right, so what do we want to do pharmacologically? We want to prevent bone loss, reduce bone fracture, or could we do both? So preventing bone loss, usually the only way you can do this is probably estrogen replacement in females, and that's a little bit risky. There are some side effects with that, and I'll talk about that here in a second. Reducing bone fracture, calcitonin, parathyroid hormone. The best of both worlds. So bisphosphonates are going to be the major drug class we're going to talk about, and they're really, if you want to break down osteoporosis to a very simple, how do you treat it, bisphosphonate's probably the only drug you actually need to know. There are some other things that are useful in people who don't respond, and so I feel the need to explain those, but bisphosphonates are some of the most popular drugs in the world, and lots of people take them. They're relatively safe, and they're the best drug in this class based on our current body of evidence. All right, so general mechanisms for improving bone health and treating osteoporosis. We want to decrease bone resorption or look at stimulating bone formation. Most agents are going to work on decreasing bone resorption versus actually stimulating bone formation. So the important thing is that inhibition of resorption leads to an indirect decrease in bone formation. Therefore, The therapies will eventually sort of reach an equilibrium point and plateau in their effectiveness. This usually takes a few years, but sometimes you'll see recommendations for therapy only to be continued for a certain amount of years, and that's because of this phenomenon that's seen with treating osteoporosis. All right, decreased fracture risk. So anti-resorptive therapy tends to result in a significant reduction in fracture. So we do have a decent body of evidence that says that if you do treat patients with these medications, you do reduce the fracture risks. Bone mineral density may not change quite as much as you would want, but you still might get a clinically significant reduction in fracture, which is beneficial. So sometimes the T-score might not necessarily reflect the actual benefit, is what I'm getting at with those points. All right, let's talk more about bisphosphonates. So bisphosphonates are first-line therapy for pretty much every patient. Their major mechanism is that they mostly inhibit bone resorption. Side effects, again, I said, are minimal. There are 4 options on the market. You might see other drugs that sound like these. There are some other bisphosphonates on the market, but they aren't approved for osteoporosis. They're approved for hypercalcemia, mostly with oncology-related indications. Bisphosphonates generally are all dosed intermittently, meaning they're like once weekly or IV therapy every so often, and they're makes it, on the surface level think, well, I don't have to take as many pills, but remembering to take something once a week is actually pretty challenging for the average person to do. It's more challenging than daily. Once daily is pretty much the best for compliance. Once you go to once weekly, it can be really difficult for somebody to remember what day of the week they took this. So we'll talk more about that in a second. So bisphosphonates inhibit osteoclast activity, promote osteoclast apoptosis. They're released locally during bone resorption, which is kind of interesting. So they inhibit the osteoclastic activity, and then they're re-released, and they almost get recycled into the bone. Bisphosphonates have very interesting pharmacokinetics, and I'll talk about those more in a second here. But basically, they sort of reuse themselves over and over again and don't really get eliminated from the body, which is another reason why you might see recommendations to only use them for a certain number of years and then stop, because they're probably still going to be active in the body several years after you stop therapy. All right, starting a bisphosphonate, evaluate for potential corrective causes. So you want to maximize your vitamin D and calcium, get your baseline labs, recommend exercise, those types of things. One of the major things that bisphosphonates can cause issues with is if they get stuck in somebody's esophagus, they can cause pretty bad problems as far as damage to the tissue. So any esophageal abnormalities like strictures or history of achalasia would be something you would want to check for first. Renal function, they are renally eliminated, so that's something we want to look at as well. And the products are mostly going to be interchangeable based on patient preference. As far as efficacy, they're all about the same. The 2 most common ones you're going to see are alendronate and resendronate. Alendronate's Fosamax, resendronate's Actonel. And they come in some different formulations or different doses and different recommendations. All randomized trials with these have shown an increase in bone mineral density and decreased fracture risk. However, the interesting thing I'll point out is that trials were done on daily dosing, and they ended up doing a once a week dose recommendation for actual practice. I don't know why they did that. Maybe if it was overall safety profile was better, but it's always interesting to me because you see this a lot in medicine where a drug will get approved or studied using a specific dosing regimen, and then they go to market with something slightly different, and you're like, well, why didn't you just use the regimen? It makes everyone a little nervous. Like, why did you change your mind here? Alendronate and I think resendronate is also now recently generic. I can't remember. Actonel was brand for quite a bit longer than Fosamax was. But anyway, the point is you have generic, inexpensive options. Alendronate specifically. Alendronate's by far going to be the most common one you see out of all these. Both were compared in one clinical trial and showed that alendronate increased bone mineral density more than resendronate. However, when it came down to actual outcomes, clinical outcomes with reduction in fracture rates, they were both equal. Ibandronate is Boniva. It's a once-a-month dosed orally, so it has been shown to be non-inferior between monthly and daily dosing regimens, so they studied it. And again, these drugs last a really long time once you take them, so that's the other question too. Maybe that's where they went back with the clinical trials and like, well, do we need to give these daily? Let's just try once a week, and they kind of found a happy medium there. Anyway, ibandronate is once monthly. The monthly regimen was statistically superior to the daily regimen in terms of bone mineral density elevations across all sites at year 2, which is kind of interesting that even giving it once a month versus once a day, you're seeing better results even, and also proving non-inferiority. So there's some interesting ways that they've studied these drugs. And again, it just goes to show you how odd the kinetics are with these. And again, the half-life, I don't even think we really understand how long they stay in the system. So that's kind of another topic in and of itself. But pharmacokinetically, they're very interesting medications. Ibandronate does come as an IV product, so there is that option for people who can't take orally. So for people with esophageal abnormalities or strictures, or have difficulty swallowing, or can't stand up for long periods of time, or whatever it may be, IV products have an advantage there because you can give them without by bypassing the oral route and basically reducing the risk of that side effect altogether. Whereas hip fracture and vertebral fracture, remember when we're looking at fracture reduction, the two major ones they look at are hip and vertebral. Hip fracture reduction wasn't well established in clinical trials for this particular product. It was for the other two. Zoledronic acid is an IV only product, doesn't come orally. It was studied as a once yearly product. It's just a 15-minute infusion. It's kind of expensive, but when you compare oral doses on a monthly basis, you're probably coming out around the same amount of money. For people with issues with compliance or non-tolerance to the oral forms, it's a really good option. Good efficacy. Long-term safety data is a little bit lacking, but that could be said for really any of these products. All right, I've kind of talked about the half-life a lot. Obviously, I find it quite interesting. But bisphosphonates, again, have these binding preferences on bones, and they get turned over and reused and continue. So some people will argue that bisphosphonates can last for more than 10 years, again, depending on the rate of the bone turnover. So because of this unpredictability and ridiculously long duration, there's not really a good consensus on how long you actually treat. There's sort of a general expert recommendation that after 5 years of regular bisphosphonate therapy, you probably have enough in your system to last you, well, to give you all the benefit you would need that you're going to get from the drug. It's kind of how I would look at it. It's not that you might not benefit from bisphosphonate therapy later in life. Certainly you would if you didn't start it earlier. But once you've taken it for several years, you're probably going to see all the benefit you're going to get from the drug. And despite that, and also, of course, it's still in your system for a number of years after you stop it. You could certainly restart the drug if you saw somebody at a high risk, or you don't have to stop the drug either. If you were like, well, this person's T-score is awful, they're really at high risk, they're tolerating the bisphosphonate just fine. Certainly, you don't feel like you have to stop after 5 years. Some people will do drug holidays on them too, but at the end of the day, it's provider patient preference. It's going to be an individualized treatment. There's not really a specific recommendation for what to do in those situations. So there's not a right answer there. And really, again, if they've been taking the drug regularly for a couple of years and they want to stop for a little bit, no problem there, in my opinion. And if they wanted to keep going, if they were worried about stopping it and they wanted to take it longer than 5 years, again, I don't really think there's any issue with that either. Assessing response, so we're going to check bone mineral density, do our T-scores. If you get a decrease in bone mineral density, so you want to look at things like adherence, of course, with the regimen you recommended, calcium vitamin D levels, and compliance with that. If you don't have an obvious cause, you might consider the bisphosphonate a treatment failure. However, some people will argue that you get increased bone turnover suppression within the first year of using these drugs. So to make sure you're not necessarily doing a knee-jerk reaction and taking the medication away right away, be like, oh, their T-score dropped, after the first 6 months of therapy. Maybe give it a full year to see, what kind of scores you get. You might see that score swing back up. Basically, if your decline is less than 5%, keep on going. If greater than 5%, maybe try IV zoledronic acid or IV Boniva. The other thing about bisphosphonates, in addition to not being necessarily tolerated by everyone from an oral intake perspective, they are really poorly absorbed. So if you try to give it to somebody whose GI tract just isn't absorbing, and all of us lose our ability to absorb things as efficiently as we age, bisphosphonates are certainly one of the products that will be affected by that. So in that case, IV might be better, even if the person's tolerating the swallowing component of it just fine. The IV products might be an advantage for that patient population. So that's an option too. You might just say, well, maybe they aren't responding because it's not actually getting into the system. Let's try zoledronic acid or whatever and see if we can get a better result with that. Adverse effects. So I kind of mentioned a bunch of these already, but the big ones are GI related. So reflux, esophagitis, and ulcerations. Very, very low incidence if taken properly. And the recommendations are pretty specific, but they're simple. I think take it first thing in the morning. You don't take it with food, or you take it before your first food, I should say. Nothing except for plain water. And then stay upright for at least 30 minutes or until your first meal of the day is consumed. And that's where you just need to make sure patients are educated on this. If somebody has Barrett's esophagus or some other type of esophageal issue, that's where you would recommend not using an oral bisphosphonate. Acute phase flu-like symptoms. Sometimes when people start these, they feel like kind of sick for 24 to 72 hours. This should go away. It can decrease calcium overall because of the bone turnover effects it's having. Now, again, supplementing calcium and vitamin D is an important aspect of this as well, so you'd want to have that in conjunction, so that shouldn't really be a big issue. Musculoskeletal pain people might experience. Renal impairment, acute renal failure. So if your creatinine clearance is less than 35 ml per minute, you are not recommended to take these medications. So that's another thing to keep in the back of your mind for what would be an appropriate patient for bisphosphonate. And I basically said everyone's appropriate, and it's really first line in every case, and it really is. However, if you have renal failure or if you have GI issues, then you're going to want to question whether or not you're going to want to use these medications. So I talked about the alendronate, resendronate trial. Otherwise, there's not really a lot of information out there that will compare one bisphosphonate to another. So basically, it's a situation we're in with a lot of drugs where we have efficacy claims for the products individually, but not compared to each other. So essentially assume that because they're in the same class, they work pretty much the same way, they should have the same effects. Again, maybe not the best assumption, but it's all we have to go on. So recommendations, start with alendronate, resendronate, or abandronate. There's not really a preferred option there. I would probably recommend alendronate. It's probably going to be the least expensive option on the market. If you're not tolerating or non-compliant, or your patient's non-compliant with it, consider zoledronic acid. And if you don't get a good response with that, you're going to try a combination of other therapies, which we're going to go into now. Now, the one thing I will say that I don't have on here is just to make sure your calcium vitamin D is on board as well, in addition to the bisphosphonate therapy. But really, for the vast majority of your patients in the osteopenic or osteoporosis world, they're going to be looking at calcium vitamin D supplementation and a bisphosphonate. And that's really all you have to know. What we're going to get into now is a little bit more advanced stuff on what else is on the market, what might be coming out, and ultimately what would you do differently if somebody isn't tolerating it, non-compliant, or the zoledronic acid doesn't work. Where do you go from there? So estrogen treatment is an option. This was mentioned. I mentioned this briefly as far as some of the first mechanism of action type slides, but it's not really a first line thing. You do get a lot of risk increases when you supplement estrogen, especially long term. So breast cancer, stroke, venous thromboembolism, and possibly coronary disease are all increased when you take estrogen. There's a lot of different estrogen replacement products out there, oral, transdermal. More commonly, these are used for vasomotor symptoms during menopause, so hot flashes, to reduce the risk of that. FDA has only approved estrogen therapy for prevention of osteoporosis, not necessarily for treatment. So effects on bones it's not as significant as a bisphosphonate. You get some modest bone mineral density increase after a couple of years of treatment, and maybe some. And the Women's Health Initiative did find a reduction in fracture risk after 5 years of therapy. The question is it better than a bisphosphonate? And is it worth the risk? And generally speaking, most people would say no. If you can tolerate a bisphosphonate and all you're trying to do is treat osteoporosis, that's what you should go with. Now, if you have somebody who's got menopausal symptoms on board as well, that's where estrogen might make more sense, where you say, well, let's give them some estrogen because it'll treat the menopause symptoms, and you're also going to get the added advantage of preventing osteoporosis-like effects or osteoporosis complications down the road, such as fractures. So there's not really any randomized control trials out there looking at estrogen for this, and there's certainly nothing comparing estrogen to bisphosphonates in postmenopausal women. So again, it's more of a specific patient population where you'd even consider this. And you could combine the two actually if you wanted to. So you could certainly have a patient who's postmenopausal on some sort of hormone replacement to help with the vasomotor symptoms of menopause, but it doesn't mean you can't be on a bisphosphonate too. So hopefully that sheds a little bit of light on where you'd use estrogen. Again, there's a bunch of estrogen products on the market. Most people don't take them long term. And again, I kind of talked about those options already. I put this up here. I always think this is kind of like a fun fact. Prempro and Premarin. Premarin is called conjugated equine estrogens, and actually they take the urine from pregnant mares and pull out the estrogen component of it. So Premarin stands for pregnant mare's urine, which is kind of a funny brand name. And Prempro is a combination product that includes that with a different hormone as well. So anyway, in case you're wondering and you want to impress somebody with horse urine, there you go for your fun fact for the day. Raloxifene or Avista is a SERM, which is a selective estrogen receptor modulator. SERMs have a number of different uses. I have a bullet point down here about tamoxifen, which is a SERM that's focused on breast cancer treatment. So different ones target different specific estrogen receptors. Avista was designed specifically for the treatment of osteoporosis, osteopenia in postmenopausal women. It's an oral tablet. It's kind of expensive. It's not super common. Its bone mineral density increases are modest at best. It does have some interesting clinical data, though, that shows a proven vertebral fracture risk reduction, and it has quite a few years of safety and efficacy. There is maybe some side evidence that says that taking raloxifene does reduce breast cancer risk. And if you need it for breast cancer prophylaxis, it might be used independently even of its bone mineral density effects. So there is some evidence there. Because it interferes with estrogen receptors, though, you might get actually some hot flash-like symptoms, increased risk for venous thromboembolism or leg cramping with the drug. So it's not a super popular choice, but it is an option in the arsenal. Again, it would be kind of like something for offering a non-bisphosphonate tolerating patient a different alternative. Again, a postmenopausal woman would be the target market for this product, and somebody who didn't want to take estrogen for the reasons we talked about here with the different side effects associated with it. I'm not going to go through this, but these are here for your review if you'd like to just kind of look at different hormone replacements. Parathyroid hormone. So we have a couple analogs. Teriparatide or Forteo is the older drug in the category, and it's a recombinant human parathyroid hormone, which is not the full parathyroid hormone sequence, but it's got 1 through 34. The full length is 84 amino acids, so it's a little bit shorter than the full chain. It's a subcutaneous injection. It's kind of expensive, but it's dosed once daily. So not maybe the most convenient choice. A lot of people kind of balk at the idea of injecting themselves with something unless they're used to that, like a diabetic patient or something. May cause hypercalcemia. Long-term safety issues aren't really well understood. You do stimulate bone formation by activating bone remodeling. So there's a bit of a different mechanism here than what you're going to see with a bisphosphonate. So if somebody did fail bisphosphonate therapy, there is an option to try a PTH analog, and it might have a different effect on that person. There's a newer drug called abaloparatide, which I've actually never seen, or Timlos is the brand name. It's going to be a bit more expensive, and I don't think there's any, as far as I could tell, there's not really any advantage over it than teriparatide. You might consider this if somebody has really severe osteoporosis and they're a new case. So there is some evidence that parathyroid hormone might be a little bit more of an aggressive approach to treating osteoporosis. And so if somebody has a really severely low T-score, that could be something to look at. Bisphosphonate issues, of course, would be another thing too. If somebody can't tolerate their bisphosphonate, PTH products would be an option. There's a newer product, I should say, called Prolia or denosumab. It binds to something called rankle, which prevents osteoclastic formation. So rankle stands for, you can see it there, receptor activator of nuclear factor kappa B ligand, which doesn't mean anything to anyone. But basically, the bullet points below are where it's important. Osteoblasts secrete this rankle substance, and rankle activates osteoclast precursors, which increases serum calcium. And so denosumab binds to that specific item, preventing those things from happening. So basically what you get and what we care about is that you get the decreased bone resorption and increase is in bone mass. Overall, it's shown to be helpful in both improving bone mineral density and reducing fracture risk. It's expensive. It's a biologic product. So remember, anything that ends in mab is going to be a monoclonal antibody, which means it's biologically produced and therefore expensive. Also used for some different different indications, especially oncology related things too. So you might see it there if you practice in that arena. A newer drug called Evenity or romosozumab. Sorry, trying to figure out how to say these new drugs. Another monoclonal antibody, again, ends in mAbs. This is a biologic product. It's in a different mechanism yet again. So again, another option in the arsenal to treat this that's sort of different from our other ones. So it's a sclerostin inhibitor, and I don't care exactly what these drugs are, just that they exist. And that includes denosumab as well. Just know that they're alternatives. You want to use in high-risk patient, multiple fractures, bisphosphonate failure, kind of the same things we've been talking about here. Dosed 2 injections once monthly for 12 months. Basically, that's it. So it's you kind of give it for a year, and then that's all you really have to do. So after that, you could consider more therapy, but they don't actually recommend continuing with this drug, interestingly enough. So they'll say if you want more therapy after you've done your year of Evenity, you go to a bisphosphonate or you try Prolia or denosumab. The major side effect is neuromuscular and skeletal arthralgia. It's expensive, but again, you don't take it for that long. So in the grand scheme of things, it's not terribly expensive. I'm actually surprised it's not more, because usually drugs that have limited time frames for use, they kind of tend to jack up the price to make up for that. So I don't know. It's not cheap, but it's not as expensive as I thought it would be. Calcitonin is not generally a recommended option. It is an option, though. There are a couple products. There's an intranasal and an IM product. There's no oral calcitonin. The effects are pretty modest. It's really just a short-term thing, and if it may be effective, especially if somebody has pain associated with a bone fracture, but you wouldn't really use it that long. And its role, as far as what I see, is mostly for treating hypercalcemia. So we give it to reduce calcium. Long-term issues, there's lots of risk associated with increase in cancer rates in various different studies. However, overall risk is pretty low, and the meta-analysis are not the best out there. However, there are better drugs on the market, and overall, this one's probably not worth the risk for the most part, and pretty much going to be reserved for hypercalcemia, and very, very rarely would you use it in someone with osteoporosis. So out of these other options, what exactly are we looking at here? I think, usually if you're trying to think about, well, do I add something on or do I keep the bisphosphonate? Combination therapy hasn't really panned out to be well proven as far as decreasing fracture risk. So you really don't get much additional benefit. You might get a slight additional benefit, but it's going to be small, and there's no real proven additional fracture benefit. The only thing is that bisphosphonates and estrogen may be slightly more effective than either alone. Again, that applies to a very specific patient population, right? So for postmenopausal women, if you're trying to treat osteoporosis, the moral is to use bisphosphonates, but you can also include estrogen if you think it's appropriate for your patient. So you kind of get an added advantage in those patients where you have some flexibility on your choices. Other than that, your basic strategy, again, bisphosphonates are really key here. Parathyroid hormone analogs would probably be the second option based on cost and efficacy and side effect profile. Your biologics, your newer ones, your Prolia or Evenity would be your third choice, and then estrogen kind of plus or minus if your patient met criteria for using it. Other populations for male patients, we're really doing the exact same things. I would consider hypogonadism in a man, so look at checking testosterone levels, and testosterone therapy may be something that would benefit them. Otherwise, the treatment's the same as women. So we're going to do calcium, vitamin D, bisphosphonates, parathyroid hormone in severe cases. Premenopausal women, so oral contraceptives and hormone replacement therapy. If you're of childbearing age and or on glucocorticoids, oral contraceptives can help with the symptoms of it can help bone mineral density increase. So you do get an estrogen component from that. If your patient is I think of like a premenopausal woman on glucocorticoids, like a younger woman who's a transplant patient taking prednisone daily, or somebody taking prednisone for some other reason. But that would be another person to consider hormone replacement therapy on. Bisphosphonates would certainly be okay, but they may actually cause fragility and accelerated bone loss. And in younger patients, we don't really know what the long-term effects of bisphosphonates are. And then you get really into the weeds when you talk about the long half-life of them and the 5-year recommendation. It's like, well, what if your patient's 20 when they start taking them? Is that really so? Because a lot of, I'm kind of generalizing here, so I apologize, but because it's relatively common, I should say, for premenopausal women to be taking some sort of oral contraceptive, it may make sense for that to be the treatment of choice, but certainly bisphosphonates would be a good option too. But again, you just have to think about kind of the no man's land of studies you're going into where we don't have as good of evidence in that particular group of patients as far as what long-term safety issues versus benefits we're going to experience. So that's it. That's the lecture. Got a couple as far as bone mineral density goes, and as far as treating osteoporosis goes. Again, bisphosphonates, calcium, vitamin D, parathyroid hormone, those are the really big take-home points. The other ones are sort of ancillary and depend on what stage of life your patient's in or how well they're doing on the other therapies. A couple other things to talk about really quickly. Glucocorticoids, I mentioned these a couple of times, and just I put a slide in here on how they interfere with bone mineral homeostasis and some of the things we can consider. So just for your reference, they're there. Hypercalcemia, I mentioned this a bunch too. There's a couple options here as far as causes you might see and some symptoms as well that might come about with hypercalcemia. Again, really hard to get hypercalcemic on a high calcium diet. Mostly you're going to see some sort of a volume depletion status or some sort of a diuretic related interference that's going to cause that. But it's possible, especially if you're slamming lots of vitamin D and lots of calcium, you could potentially push yourself that direction, but it would be difficult. This is hypercalcemia treatment, how we treat hypercalcemia. The only thing I'd really want you to know about this is that mild, really, we don't do anything with it. So it's really rare to see somebody with a calcium is high enough that you'd actually want to give some calcitonin. But basically, somebody does come in with really high calcium, you want to dilute it out with hydration. You could consider calcitonin. Loop diuretics too will eliminate calcium. Severe, prolonged, or resistant bisphosphonates. I kind of mentioned that there's some other bisphosphonates that are designed specifically or approved specifically, I should say, for hypercalcemia related to oncology, and so sometimes those will get used in this. I actually just had a patient this last weekend who we gave a different bisphosphonate IV to because he was profoundly hypercalcemic and he had a lot of different health issues going on, so I'm not going to get into him, but overall there are a couple options out there. So basically, the moral of the story is we don't really do a whole lot, and if we do, it's probably going to be a dose of calcitonin. That's usually a one-time IM thing they give, and that should bring it down enough. And if you need to continue, you're just going to make sure you hydrate and maybe use some loop diuretic to get rid of it. Paget's disease is relatively common, but symptomatic bone complications are quite rare with it. We don't really understand it too well. I'm not going to really test you on Paget's disease at all. There's a treatment there for it. And then enteric oxaluria is short bowel syndrome associated with fat malabsorption. So you get renal stones composed of calcium and oxalate. normal urine calcium levels, but high oxalate levels. Calcium binds to fat, and treatment is calcium supplements, actually, because so you're absorbing calcium, but your body's binding it up in a way that makes it impossible to use. So we supplement to give you more to be able to use, and it's sort of counterintuitive that way. But anyway, that's sort of a rare thing. And if you work with patients with different bowel syndrome, especially short bowel syndrome, that's something you might encounter. All right, that's all I've got for this lecture. We will see each other next week, and I'm going to post the opioid conversion problems and the key for them. So if you want to get a head start on those a couple weeks out from the exam, you have plenty of time to do so. And we'll go through one during class. I think there's an example on the next set of slides for the set of slides for rheumatoid arthritis. So if you want to practice or look at those, you can go ahead and look ahead. But other than that, I will see you guys next week. And thanks for tuning in today or tomorrow or whenever you watch this. And I appreciate your time.